Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Prasad Katta. Dr. Katta is board certified in internal medicine and endocrinology.
The most common metabolic disorder, as all we know, is diabetes. Okay, and the first part of my talk is on diabetes. Some of the slides you may have seen before in either my talk or other talks. The second part, I'll be talking about a condition called metabolic syndrome. That also is a fairly common disorder, I should say, because it's a constellation of disorders. That's we have to treat the individual facet of the disorders each way. So now the third part of my talk, I wanted to include something with respect to metabolic, so I choose to have something about thyroid also. So thyroid is directly not a metabolic disorder, but we does deal with your metabolism, and it's a fairly common condition which you come across in the population, so that's why I just wanted to do that also. Okay, so the title of today's talk is your blood pressure, glucose level, even your waistline may be telling you something serious. So again, as I said, metabolic disorders occurs when a defective gene causes an enzyme deficiency or a hormone deficiency, and these disorders, which are many subtypes, are called as inborn errors of metabolism. We are not going to talk about these. These are usually very, very rare and usually are treated in like tertiary care centers or quaternary care centers like either Stanford, UCSF, and probably the attendings there or the professors there maybe see 5 or 6 patients in a day. So, but they are very rare, so we won't be talking about that. So, metabolic diseases can occur when a liver or pancreas do not function properly. So, again, we'll be talking about with respect to the diabetes, the pancreas doesn't function properly. There are other causes for high blood sugars too. I'll go into it later. We won't be talking about the inborn errors of metabolism as I discussed, but more the acquired metabolic disorders. So diabetes, what is diabetes? It's a lack of insulin and also resistance to insulin which is already present, making your blood sugars to go high. Type 1 is the rarer form, about maybe 5 to 10%. 10% I would say is probably overestimating it. Type 2 is more common, almost 95 to even 96, 97% you can say. The metabolic syndrome, this is what I said earlier, will come into the talk later, is a cluster of conditions that occur together. It definitely does increase your risk for heart disease, stroke, and also type 2 diabetes. And these conditions include a risk of increased blood pressure, high blood sugars, the excess of body fat around your waist, and abnormal cholesterol and triglycerides. So, definitions. What is diabetes? It's a disorder of abnormal blood sugar levels. It's a defective insulin production or its use in the body. When we say its use in the body is though insulin is being produced, it's not being utilized properly because of the insulin resistance and other reasons. And we all know insulin is a hormone made by pancreas to regulate blood sugar. So, this is just a representation with respect to who are at risk for diabetes. What is the lifetime risk of diabetes in a person born or people born in the United States in the 2000? It's 1 in 3 Americans here and 1 in 2 of Hispanic females and 2 out of 5 of African Americans or Hispanics. This has actually not changed that much. Actually, it's probably gotten, I would say, worse than what it is presented here. And this was again it was presented in like 2006 here, and the risk is in the year 2000. So, what is the prevalence, the number of patients who have diabetes in, actually it should say it's 2017, I apologize for that. In 2017, it's about 30.3 million, and that's about 9.4% of the population. 90+% have type 2 diabetes. Undiagnosed is about 7.2 million. So, if you say almost 1/4 of them don't know that they have diabetes. So, if anyone is at risk of diabetes or do have diabetes, you need to let your family members know to get it checked for sure. And about 85 million patients have pre-diabetes, and these are the risk of developing diabetes down the line. So, they also need to sort of see their physicians and get checked. So, what are the risk factors of diabetes? Certain medications definitely is a risk factor. Means if someone is taking steroids, things like that, the prednisone or any other form of steroids, that can cause diabetes. There are other medications like antipsychotic medications where patients tend to gain weight and they can cause diabetes too. Definitely race is a risk. As I said, Hispanics are at high risk, African Americans, South Asians are at higher risk because of the genes and also because of what they eat. And patients who have blood pressure are also at higher risk. Patients who have blood pressure have in turn can develop diabetes, and patients who have diabetes are also at risk for blood pressure. We'll come into that later. Stress is definitely a risk factor. Again, we can't really say how much it sort of hurts people or patients, but we know that it is a risk factor. And patients who have diabetes, when they have more stressful episodes at work, other reasons, their blood sugars tend to go up, at least I would say by 20 to 30 points or 30 to 40 points. It does not go up by 100 points, but yes, definitely it can go up. Age itself is a risk factor for diabetes, because as a person ages, the pancreas, the insulin producing capacity of the pancreas decreases. And when someone is diagnosed with diabetes, a person already has lost 50% of their capacity to produce insulin. So, that is like in the next, let's say they live for another 30 years or 40 years, they have to live with that 50% and to preserve it as much as possible to control the diabetes. Inactivity is one. Pregnancy, again, this is a risk factor, especially if they have a family history, because pregnancy is an insulin resistant condition. The placenta produces hormones which makes the mother more insulin resistant. So, that's a risk factor too. High cholesterol, obesity, and family history. So, this is just a cartoon figure showing that obesity and type 2 diabetes, and here the pancreas is saying that it will go on strike. So, basically because of eating junk food and probably not exercising, so on and so forth. This is another picture which just shows that over the so many number of years we have gone from hunter-gatherer to a couch potato. So, that's one of the reasons why we have developed more diabetes in the long run over the last 100 years. So, diagnosing diabetes. So, it's not changed much. ADA slightly changes things once in a while, but over the last 2-3 years that's not changed that much. And again, if someone is diagnosing diabetes based on blood glucose, it needs to be above 126. Normal is less than 99, and someone who's pre-diabetic, it's between 100 and 125. So, we don't call borderline diabetes, we call it pre-diabetes, or you're at risk of diabetes. And again, if you're not very clear, sometimes the other thing is we use is the A1C, which is the average blood sugar for the last 3 months, and that A1C needs to be above or equal to 6.5. If you're less than 6.5, then you are still in the pre-diabetic range. If you're above 6.5, you are in the diabetic range. And these two things the ADA does say on 2 separate occasions. Sometimes you don't need the 2 separate occasions because you already have a 6.5 or 6.6, and your fasting sugar is greater than like 130 or 135. It should be greater than 126, but if it qualifies for that, that should be more than sufficient. There is another way we also can do the oral glucose tolerance test. We usually do it in pregnant patients. In usually non-pregnant patients, we usually don't do it. because we can't diagnose it with the A1C, where we give a glucose load and then we do the blood sugars before giving the glucose load and then again at 2 hours later. So, what are the common potential complications of diabetes? Heart disease is the most common, okay, and stroke. So, this goes together. Kidney disease, the most common cause for dialysis in US is diabetes. Eye complications is the other one. Diabetic neuropathy and nerve damage, that again can lead to amputations and foot complications. This is rare, gastroparesis and diabetes, where patients' stomach slows down because they've had diabetes for a long time and they don't control their diabetes. The stomach also has nerve supply and those nerves get affected, and if that is the case, definitely that can also slow down the stomach and they present in the form of nausea, vomiting, so on and so forth. Depression is one. Infection, there's a higher chance of infection because of their immune system sort of doesn't respond as it should because of the high sugars. So, this is a slide again in 1995, but I don't think it's changed that much. Almost 2/3 heart disease and cerebrovascular disease, the cause of mortality, cause of death is almost 66% is heart disease and stroke. So, the other 35% is diabetes itself. This year it could be kidney disease and other things, and other causes are pneumonia, other things, and malignant neoplasms or cancer. So, we can say it's scary stuff, but not exactly. Why do I say that? Treatments are much better than 10 or 20 years ago. So, even when I started practicing, which was 15 years ago as an endocrinologist, we had probably about 3-4 medications and maybe a couple of insulins, or 3 types of insulins, 3 or 4 types of insulins. But a lot has changed over the last 15 years. Again, as I say there, it's not your father or mother when they had diabetes. Many cases, type 2 diabetes is preventable and are controlled for a long time without complications, and also can prevent heart disease. So, what are the ways we sort of control diabetes? We go with the ABCs of diabetes. This is again very commonly known. Okay, A stands for A1C. That's the red blood cells which are there. You've heard of probably hemoglobin. Hemoglobin is the content of the red blood cells in the body. So, hemoglobin A1C is the blood sugar coating content of the red blood cells in the body. So, that again, as I said, in depending upon which organization you use, you want to be less than 7 or 6.5, and this is the normal person, and this is the, let's say, diabetic person who's not controlled. They have more of these blood sugar content on the red blood cells. A1C is the blood sugar check with memory over the past 2 to 3 months. B stands for blood pressure. ADA recommends a blood pressure of 130/80, and that if you are able to get that to 130/80, it's pretty much good by any standard, unless if you're a cardiologist or any other doctor, if someone is seeing, you're saying that you want to be 120/80. C is for the cholesterol. Again, we concentrate mainly on the bad cholesterol. LDL can clog your blood vessels and lead to heart disease, and also or clog other blood vessels. That's one of the things we concentrate on. The HDL can protect your heart, and triglycerides can also increase your risk for heart disease. There's no clear evidence on this, but we think it may. So, going further, now I talked about ABCs, we finished these 3. D stands for diet, E stands for exercise and also eye exam, and F stands for foot exam. G stands for glucose monitoring. Someone who has diabetes, we have to want them to check their blood sugars. How often, things like that, I'll come into that later, but again, we want them to check their sugars, so that way they are aware what they need to do if they are high or what they need to do if they are low. And H stands for health maintenance. When I say health maintenance, it depends upon the man or woman, how often they need to, if it's a woman, mammograms, okay, their pap smears. In men, a rectal exam, test for prostate, colonoscopies, all those things also needs to be taken care. So, health maintenance is a very important thing. So A1C is average glucose here. Again, if you look at it, 5 corresponds to about 97, it's actually around 100 I would say, 7 is about 154, 9 is about 212, 11 270, 13 is like 330 and 14 is about 360. So this is what we need to aware. So if you want it to be controlled, this is the cutoff here. So 7% or lower. Again, when I say 7% or lower, it's not written in stone. It depends upon the person who has diabetes. If they have limitations, I'll come into that later, we can allow them to be around 7.5 or 8. But usually we say 7 for most patients, as long as their quality of life is good, they are able to do their routine stuff and things like that. So if they are not, if they are more prone to low blood sugars, then higher sugar should be okay. So the ADA guidelines, how often we need to check A1C? We want to check A1C at least 2 to 3 times if you're meeting goal. That's pretty much, that's basic what ADA says, 2 to 3 times a year. Okay, and quarterly for whose therapy has been changed or not meeting goal. So that's like every 3 months. And if the patient is not compliant, if they're not coming for exams or getting their blood test done, whenever they come into the office, we want the physician to check their A1C. There are tests which we can do it. You don't need to go to Quest or LabCorp or Washington Hospital to do the blood test for A1C. We can get it done even in the office. Some offices maybe have it, some offices may not have it, and you can just get it done by a finger prick, and it's very reliable compared to the blood test too, and you don't need to fast for it. So you can get it done at the point of care testing and monitor the timely changes. What medications to use? Type 1 is always insulin. Again, I'm not going to talk much about type 1 because the total audience will be different, and it means though it's a metabolic disorder, we're not going to talk about it here. Type 2 combinations of pills, insulin, and other injectable. So there are a lot of pills. I'll go into a few details. I'm not going to all the details about the medications, but if there is any questions, I'll be more than happy to answer. Insulin, there are long-acting insulin, short-acting insulins, and also combined insulins. And other injectables, these are known as GLP-1 analogs. They're newer medications. They've been there for about 14 years, I would say. And medication selection in type 2 diabetes depends upon where they are at their blood sugar control. That's what it depends on. Many new medications are on the market for the last 10 years. 3 main categories of medications, again, oral pills, as I said, newer insulins, more modern insulins, and non-insulin injectable medications. So the choice again allows us to individualize the patient's treatment depending upon what conditions they have, whether they're prone to low sugars, what about their kidney functions, and so on and so forth. Different medications and different situations and patient limitations. So I just want you to focus on this. I don't know how much you can see, but you probably should see it in your handout. This is high blood sugar here. There are different causes of different reasons why the blood sugar goes high. One is the pancreas. Okay, it does not produce enough insulin. The liver, it produces too much glucose. Okay. Also, your intestines produce hormones they're called incretins, and they indirectly also lower your sugar. So if your intestines is not producing these enough hormones, because these hormones indirectly affect the pancreas and also the liver in the right way to produce insulin or decrease the production of glucose from the liver, you can also have high blood sugar. And also if you break down fat, that can lead to high blood sugar. And the kidneys, not only we used to talk kidneys about, let's say 5-6 years ago, we only knew kidney that it was a problem if you don't control your sugars, and the complication could lead to kidney disease and dialysis. But now there's medication which can control sugar by using the kidney as a mechanism. So that's one other positive thing which has developed in the last 6 years. And also because of the muscles does not take up enough glucose, there is the insulin resistance there, so that also can cause to high blood sugar. And inflammation can cause high blood sugar. And there is also resistance at the blood vessels that can cause high blood sugar. So, all these things can cause high blood sugar. Initially I said only the pancreas does not produce insulin, that is one of the main things, but all these things can cause. So, now if you look at it, there are different medications at each level. At the fat level, we have medications called TZDs, called pioglitazone or lactose, you may have heard of it. The kidney level, we have the newer medications, they are called SGLT2 inhibitors. Some of them you may have heard it on the advertisements, Invokana, Jardiance, Farxiga, those are the ones. That again, at the muscle level, it's the TZDs, which is the pioglitazone or lactose. Liver, the level of the liver, it's again the TZDs which act here, also act here. Metformin, which is the most common medication used for treating diabetes, and the GLP-1 analogs also. These are injectables, but they are not insulin. They can be used once a day, once a week. Those are the ones which are available right now. And there is another medication called DPP-4 inhibitors. These also act on the incretin and indirectly act on the pancreas and liver to reduce the glucose. And on the pancreas itself, we have like the GLP-1 analogs, we have the DPP-4 inhibitors, and one of the medication which is left off here is the sulfonylureas, which is the glyburide, glipizide, glimepiride. Those are the other ones. So, they have different medications to sort of target different actions, but in the end result we want to decrease your blood sugar. And again, this slide I just wanted to show it there because we have two organizations, the ADA, American Diabetes Association, and there's the next slide. This slide is the American Association of Clinical Endocrinologists. Both of them have come very close to each other because ADA was a little more insulin centric about 3 to 4 years ago, but they do want you to try and use medications. But again, initially it's metformin, diet and exercise, that is lifestyle management. The second treatment, any medication can be used, including insulin. Okay? And if they are not at goal after 3 months, or depending upon when the physician wants to check the A1C or other methods of monitoring the sugars, then they have to go to the third medication or add the third option, and any of these medications which I mentioned earlier can be used. And everywhere lifestyle management continues to, we also have to stress to the patients that they have to continue to use your diet, exercise, things like that to manage their sugars. So, this is another slide which I wanted to show because again, as I said, it's an individual treatment plan for each patient. Okay? Why is that? Okay, so if a risk of hypoglycemia, if there is someone who's having low blood sugars quite often, then we try to keep them less stringent. We may keep it at 7.5, we may keep it at 8. If disease duration, if someone has had it for 30, 35, 40 years, we may try and keep it a little bit higher because they may not be that motivated to take care of them at that time, and they may have had complications, so on and so forth. Life expectancy, if we think someone is only going to last 5 or 7 years, and again they're like, let's say 78, 82, 85, then we may say higher sugar is okay for them. If not, if a younger patient 35, 40, we want a lower sugar, we want A1C of 6.5. Relevant comorbidities, yes, especially heart disease, stroke, we can keep it a little bit higher because it has been shown in some of the studies, patients who are at a higher risk for heart disease, stroke, we don't want their blood sugars to be too low because they are at a higher risk for sudden cardiac death because if their sugars are too low. So, that's the reason. This is what I was talking about, established vascular complications. Patient attitude and expected treatment efforts. If they are less motivated, then probably we don't have a choice. We tell them at least you have to discuss with the patient, tell them about what their goals are and try to achieve them. And resources and support system, that also is an important thing. If I have a lady who's 85 and then she's on insulin 4 times a day, she lives alone, I don't want her to have lows because there's no one there to take care of her if she has a low. So, I am okay for such a lady to have a higher sugar, so it's not an issue. So, this is the American Association of Clinical Endocrinology guidelines, very similar, they are a little more aggressive. They want it, the A1C to be less than 6.5 if you are able to make sure that you don't have that much hypoglycemia, more than 6.5 for patients with concurrent or serious other complications, or at risk of hypoglycemia, you can keep it more above 6.5. Again, until 7.5, they're saying, okay, you can use one medication, but if your A1C is above 7.5, they do advise to use two medications. As I showed you in the figure, that the different organs causing the high blood sugar, we have to try and target each of the organ and try and harness the potential of that organ to lower the blood sugars. And if it is more than 9.5, they definitely want you to take 3 medications. And if you have symptoms, especially increased urination, increased drinking water, eating more, then you may have to even use insulin. Again, one other thing which is very important, which sometimes even as physicians we forget to mention, is the progression of disease. It's a progressive disease. What worked for someone 10 years ago may not have worked for them 7 years ago, and may not have worked for them 5 years ago. It may not work right now. So you may need to use more medications as the disease progresses. Again, it doesn't happen in every patient. In a lot of patients it does happen, in some patients it may not, especially if they're controlling it good. So B stands for blood pressure. So again, up to 20 to 60% of adults with diabetes have high blood pressure. It increases risk for kidney disease, heart attack, and stroke. Target blood pressure again is less than 130 by 80, as I said. Many patients need more than one medication. You can't just control with one medication. You may need more than one medication. So you may need to be on a combination of medications, and that's what usually physicians do. If they add one and it doesn't, if they start one and it doesn't work, they may go to the next one. Again, these are the different blood pressure medications: ACE inhibitors, lisinopril, enalapril. These are usually the ones recommended for diabetic patients. The ARBs, which are alternatives. This is the Diovan, Cozar. Most of these are, these are all generics. Diovan is valsartan, Cozar is losartan. Beta blockers, these also protect your heart: atenolol, metoprolol. There's another one called carvedilol. The fourth group is the calcium channel blockers. This is the amlodipine, you may know, diltiazem, nifedipine, and diuretics like hydrochlorothiazide, furosemide, and others. So key steps to lowering your blood pressure: eat more fruits and vegetables, reduce the amount of salt in diet. I'll come again in the metabolic syndrome, I'll talk a little bit more about that. Lose weight, lower alcohol intake, quit smoking, take blood pressure medications if needed. And most patients require more than one pill. So with respect to blood pressure, that's about it. I'll be talking again in the metabolic syndrome part of it. Cholesterol, C stands for cholesterol. Often abnormal in adults with diabetes, okay, increases the risk for heart disease, stroke, and amputation. New guidelines, okay, even according to the American Diabetes Association, every diabetic needs to be on a statin. The statins are the ones which control the cholesterol. The reason for that is it has been shown patients who are on a statin, in the long run, they have a lower risk for heart disease and stroke. So that's the reason. Again, some of you may not believe in statins here, but there have been enough studies to show that they definitely work on reducing morbidity and mortality. By what I mean is your heart disease risk and also for your risk of your stroke. LDL, again, with respect to, this is the bad cholesterol, LDL. Usually 100 is the target, but again less than 70 for high risk. I personally consider it needs to be 70 or lower. Triglycerides, which is the other component of the cholesterol or the lipid panel, needs to be less than 150. Good cholesterol in males greater than 40 and in females greater than 50. And one other thing is, usually if your triglycerides are high, you can calculate your non-HDL, which is very easy. Total cholesterol, which I have not mentioned here, minus your good cholesterol is the non-HDL cholesterol, and as long as that is the bad cholesterol plus 30, the total needs to be less than 100. If you're less than 100 for the non-HDL cholesterol, then you are pretty much achieving your LDL goal of 70. Again, cholesterol medications, statins are the most common ones used for controlling bad cholesterol. The others are Zetia, which is ezetimibe for controlling bad cholesterol too. Fibrates, which is fenofibrate for controlling triglycerides. and omega-3 fish oil for controlling triglycerides. And there's niacin also, which we rarely use nowadays, but I just wanted to mention it. So key steps in controlling cholesterol: foods for saturated fatty foods like fatty meats, high fat dairy products, and eat foods which are high in fiber. Take cholesterol medications if they are recommended to you, and exercise regularly. So meal planning, it's always better to work with a dietitian to develop your own personalized meal plan to help you lose weight if needed, and choose foods which are low in carbohydrate and fat. This is for your diabetes, and this is for your cholesterol, and to some extent your blood pressure too. And include a variety of foods including whole grains, vegetables, fruits, meats and dairies. Portion control is key, and one easy way to do your portion control is hand guide to portion size. So if you look at your palm, 3 ounces of poultry, meat or fish, should be the size of your meat. And if you do eat rice or pasta, things like that, a fist, which is 1 cup full. A cupped hand is half a cup, which is beans or potatoes, and then 2 cupped hands is like chips or popcorn, pretzels, etc. Thumb is 1 ounce of peanut butter or like hard cheese, and thumb tip is 1 teaspoon of cooking oil, mayo or butter. So the one easy way to cut what are the different groups you can eat with respect to your portion size. So about exercise, what is my advice to patients about exercise? It's very simple. Exercise only on the days you eat. If you don't eat on that day, then don't exercise. Okay, if you eat on that day, you should exercise. So before starting to have a complete, I usually recommend, at least for patients who are above 65, 70 years, if you have not done any exercise, see your physician, make sure you're okay to exercise, and then start exercising. If you're a younger patient, you should be fine. Okay, it should not be an issue. Duration at least 30 to 60 minutes, minimum I would say 30. Combination of aerobic and strength training, at least 2 days strength training. Start slowly and build up gradually. Rule of thumb again is breaking out in a sweat or after exercise, your heart should be racing. So if your heart is not racing, then you probably have not had enough exercise. So, and again, the heart racing should come back once you stop the exercise. So a little bit goes a long way, trying to be more active throughout the day. Examples: gardening, play with the kids, take the stairs. At least up to 30 minutes of walking on most days. You can even split this into 3-10 minutes when it's convenient. Usually show this, what is right or wrong about this picture. Usually people say there's nothing wrong about this picture. I do agree with that, but the only thing is no one is taking the stairs down or up. So that's one thing. I do feel that if there is stairs, we need to take it either down or up at least. So most of us would like to just take the escalators, but one way to do is take the stairs. And there's definitely something wrong about this picture. You don't want to do this if you have a dog walking properly, not with your car. So glucose monitoring. I am a big believer in monitoring your sugars because that gives us some story about your blood sugar control. Again, take a logbook or a monitor or both to your physician's office. I believe in getting the monitor to my appointments because we can download the monitors, most of the monitors. Most monitors can be downloaded. Again, important to check different times of the day. You don't want to just check in the morning like brushing your teeth and forget about it. You want to check sometimes 2 hours after you eat, sometimes you go to bed. If you've had a heavy meal or you go to a restaurant, maybe 2 hours after that to see, and then go from there. I just wanted to put this up there. If there is input, there will be output. The input is your blood sugars, and then as physicians, we can give you our output. If the input is greater from the patient, our sort of feedback for you for your blood sugars will be greater. Usually I say if you don't get your sugars, it's like analogy is a blind man shooting in the dark. So there are 3 or 4 things we don't know what is going on. It'll be just going on, that's all. Yes, we can get the A1Cs and everything, but that usually completely doesn't tell the story. And again, patients on insulin, the blood sugars are the story, because without watching just like a still photograph versus watching a movie, and if there is no pain, there's no gain. So this is a cartoon which I just wanted to show. There are some of the patients, even my patients, they have a different collection of meters, but they don't use them. This is a lady show. Have you seen my collection of blood glucose meters? These are all in a glass case here. So managing medications, ask when you need to take each medication, make sure their instructions and labels are clear. Link as many medications to certain daily events like getting up, eating, brushing teeth, bedtime, meals, etc. Set your watch and your computer and the kitchen timer as a reminder. Make a chart showing each medication when it should be taken, and talk to your healthcare provider as to what you need to do if you miss a dose. Use a daily or a weekly pill box. A weekly pill box is always better, means that way you know, like, rather than doing it, pulling out your medications daily and preparing it for the next day. Weekly, you have even a monthly pill box now. It is just the weekly pill box times 4. That becomes your monthly pill box. Put a reminder whenever you need to sort of do, so that note where you will see it, or on your refrigerator, etc. So general tips for controlling diabetes: A1C less than 7. 6.5 is okay if you're able to tolerate it, as long as you're not having lows. Estimated average sugar of 154, blood sugar 130 by 80, cholesterol, I discussed this, less than 70 is better than less than 100, and good cholesterol greater than 40 in men and 50 in women. And if someone does smoke, definitely get help to quit smoking. Be active, make healthy food choices, smoking cessation, of alcohol consumptions, and talking to your doctor about medications. So again, heart disease and stroke prevention: don't smoke, treat your cholesterol to target, treat your blood pressure to target. If you're able to control all these, you can decrease your risk factors by almost like about 40%. Okay, so the other 60% is still there, but 40% you can definitely decrease it. So again, I just wanted to put up this slide again. So pretty much same, but you can take care of it, but you just have to do the things on a consistent basis. So the next part of the talk is metabolic syndrome. I have about maybe 22 slides of this. So it's very similar to, let's say, diabetes or whatever he spoke about. But again, these are not patients who are diabetic. You feel, okay, what is this doctor is talking about the same thing? Yes, because they are very similar. So it's not a disease. It's rather a cluster of disorders of your body's metabolism, including high blood pressure, high insulin levels, excess body fat, and abnormal cholesterol levels. Each of the disorders by itself is a risk factor for other diseases, and in combination, however, these disorders, they dramatically boost the chances of developing life-threatening illnesses such as diabetes, heart disease, or stroke. So this is the central part of it: obesity, that leads to blood pressure, hypertension. That also leads to, we call it atherogenic, which causes heart disease. This is the high cholesterol levels, dyslipidemia, and the insulin resistance that leads to high blood sugars. So these are, you can say it's a triad, but these are all the components. So this is a CT scan which is showing when a CT scan was taken right across the abdomen here. This is the visceral fat, which is the fat in the belly, and this is the subcutaneous fat, which is around just the abdominal wall. So the higher a patient has a visceral fat or the fat in the belly, that is the higher risk for metabolic syndrome, for the components of the metabolic syndrome, and that's the dangerous inner fat. So where do you measure your waist? That's how to measure your waist circumference, because we need to know your waist circumference to know if someone has metabolic syndrome or not. So that's why I wanted to show this slide. Locate the upper hip bone on top of the right iliac crest. This is exactly where this is the iliac crest is. The right upper hip bone. Place a measuring tape horizontal plane around the abdomen and the iliac crest. That this is the one, and then ensure the tape is snug but does not compress your skin. Tape should be parallel to the floor. You don't want to be at an angle, and record the measure tape at the end of the normal expiration. When you exhale, take in a breath, out, and then you measure it. So in women, 35 inches are at an increased risk. In men, 40 inches are at an increased risk. So there are other components. I'll come into that in the next couple of slides. Okay, you just have to measure how you measure your waist. Just take the measurement of your waist, and that should be half your height, less than half your height. Like if your waist measurement is more than half your height, that means you do have more fat in intra-abdominal fat. So that's what a very easy way of doing it. You don't need to weigh yourself. Like usually we say body BMI, which is body mass index, that takes your height and also your weight into consideration. But a very easy way of doing it is the body with respect to height to waist ratio. So as long as your waist is less than half your height, then you have probably less intra-abdominal fat and you're at a less risk for metabolic syndrome. So again, this is a cartoon figure showing metabolic syndrome. Anyone who's like this apple, or you say pear shaped here, this is central obesity, high blood pressure, the high triglycerides, low good cholesterol, and insulin resistance. The more components of this syndrome that you have, the greater risk of you're at health for metabolic syndrome. So these are the two guidelines which are there, 2005 and 2003, and actually they have not changed that much. There are a couple of other guidelines which are the World Health Organization and some international guidelines are there, but I didn't want to go into that and make it too complicated. In the NCEP ATP3, the most common ones which are used is this. What is required is any of the three, either the cholesterol less than 40 in men or 50 in women, high triglycerides greater than 150, or your waist greater than 102 centimeters in men or 88 in women, glucose of 100 milligrams per deciliters or greater, and then blood pressure greater than 130 by 85. Any of the three. And in this has to be present. It is the body mass index of greater than 25 or the waist greater than 102 and 88 in women, plus any of the two. So these are all pretty much the same as here, it's not any different. So any of the three here, this plus any of the two. So that qualifies as metabolic syndrome. And again, based on ethnicities, sometimes we may get questions, right? Okay, what if I'm an Asian? So what should I do? Usually Asians are smaller in build and so on and so forth. So they do have, for South Asians, Chinese, Japanese, there are different cutoffs here. That's why I put it there just to take a look at, but again, to see an individual patient, yes, you can follow it, but most of the studies are still done by the guidelines which are there. So prevalence, what are the number of patients in US who have metabolic syndrome? It's almost about 22% overall prevalence, and it is increasing with age. I'll show you a slide about that. And Mexican Americans have the highest prevalence, and women had higher prevalence in both Mexican Americans and also African Americans. So this is a slide about 22% of overall between 20 and 70 age group. As your age increases, it almost increases up to 50%, the metabolic syndrome. So as we all know, as we age, we also put on more weight. So that's one of the reasons. So risk of what are your risk of developing? Okay, diabetes, you have 4 times the higher risk for developing diabetes. Heart disease, you have 2 times the higher risk. Fatty liver, fatty liver is the most common cause for liver transplant in US, or it's also the most common cause for cirrhosis in US, which is basically your liver is replaced by like fibrous tissue. Sleep apnea, where patients don't sleep well because they stop breathing for half a minute, 1 minute to 2 minutes, and when they get up in the morning, they're very drowsy or groggy, and during the day they feel they don't have any energy. Gout, which is high uric acid levels in the body, that is also at a higher risk in metabolic syndrome. Chronic kidney disease and dementia, this is indirectly due to the blood pressure, the cholesterol and diabetes, not like a direct risk factor. So treatment, again, coming to the daily nitty-gritty stuff, consistency stuff, lifestyle modifications to reduce your weight by up to 5 to 10%. If you're able to achieve that, most of the individual components of metabolic syndrome may disappear. Diet, a Mediterranean diet high in fruits, vegetables, nuts, whole grains, olive oil, and also low in fat. The DASH diet, this is a dietary approach to stop hypertension. If someone has blood pressure, they should follow this diet because it does work. It's as good as taking a medication in a lot of these patients. Sodium intake and restricted to 2400 or less than 2500. High dietary intake of than Mediterranean diet with respect to dairy. And then food groups, what are the DASH diet here? If you look at the grains, it's about 6 to 8 servings. Vegetables is about 4 to 5. Fruits is about 4 to 5. Fat and fat-free dairy is about 2 to 3. Meats and poultry and fish less than 6. This is all this is per week. And nuts again 4 to 5 servings per week, and fatty oils 2 to 3 per day. Sweets is less than 5 per week, and sodium is 2300 or 2400 milligrams. Again, with respect to foods containing low carbohydrate, can control your sugars better and also improve your cholesterol. High fiber greater than 30 grams. Exercise 30 minutes a day, at least moderate intensity exercises. Treatment with respect to prevention and diabetes, metformin. That's the most common drug again used to treat metabolic syndrome, at least the component of blood sugars. Cardiovascular risk reduction, you do use the statins here. Patients are at risk. So how do you calculate it? You can calculate by using this is the calculator. It's a long abbreviation here, ASCVD. It is atherosclerotic cardiovascular disease calculator. It's very easily, if you just put ASCVD calculator in Google, it comes up. If you have your complete cholesterol panel, you can put it there, and it will tell you, basically it will ask you your age, your total cholesterol, your good cholesterol, your blood pressure. If you went to your physician, make sure you get your blood pressure readings. Then it will ask you whether you are on blood pressure medication. It will also ask you, do you smoke, and whether you are diabetic or not. Then it will give you a figure. You just go with that figure, and then it will tell you, as long as the risk is less than 7.5%, then you don't need to take any statins. If your risk is more than 7.5%, that's a 10-year risk for heart disease or stroke, then more than likely you may have to take statins. At least that's what is recommended. And blood pressure treatment, which I went into it previously, that is pretty much the same. Any of the different medications you can use there. So the last part of my talk, again, as I said, this is not a metabolic disorder. This is an endocrine disorder, which I do see daily patients of hypothyroidism more than hyper. I just wanted to talk briefly about it. I have given another presentation of a thyroid disease itself, but I just wanted to put it out there. But it's an endocrine gland which is responsible for your metabolism. So I wanted to just talk about that. So where is thyroid? Thyroid is situated here. It's a butterfly-shaped gland in the center of your neck. Okay, it's situated in front of the neck between the collarbones and below the Adam's apple. So these are all the different glands in the endocrine system. Pituitary gland is a master gland here. The pineal gland, it doesn't do that much actually with respect to function. Thyroid gland is here, and as I said earlier, the thymus, this is usually more important in children, but it does involute after that, like the appendix. It's not that functional. Adrenal gland, which sits on top of the kidneys here. The pancreas is the one which is responsible for insulin production, diabetes, etc. The ovaries and the testicles. So the thyroid gland produces hormones T4 and T3, which have an effect on different organ functions of the human body. It has an effect on the heart, skin and nails, intestines, hair, brain, muscles, temperature regulation, sleep, metabolic rate, as I said earlier, and also the bones. So I just wanted to show, this is called the HPT axis. Your physician definitely uses this when they're treating you, exactly to know where someone is hypo or hyperthyroid. I just want you to follow this. It's very easy. The hypothalamus is on top of your pituitary gland that secretes a hormone called the TRH, or thyrotropin releasing hormone that has a positive effect on the pituitary gland to secrete the thyroid stimulating hormone TSH. So, that in turn has a positive effect on the thyroid gland to produce T4 and T3. So, if you have enough T4 and T3, what it does is it works in two ways. In one way, it sends signals back to the pituitary gland to not to produce more TSH, to keep it in the normal range, and also the peripheral tissues here also send signals to the hypothalamus not to produce the thyrotropin releasing hormones. So, TSH is not secreted. So, that is how it functions. It is very simple. We call it the feedback loop system. So, it was negative feedback loop system. So, that is very common even in engineering and things like that, but in endocrinology, in most of the endocrine glands work this way. So, again, so what are we looking at? In a normal patient, the pituitary gland secretes TSH and that turns on the thyroid gland to produce the T4, and if there is enough T4, that turns off the pituitary gland to not to produce too much TSH. So, that is in the normal patient. This is the hyperthyroidism, this is the hypothyroidism. We will come to that later. So, with hyperthyroidism, the body is exposed to excessive thyroid hormones. It is about 1%, 1.2% of the Americans. About 0.5% they clinically know that they have hyperthyroidism. The other 0.7% are subclinical, and 5 to 10 times more common in women than in men. And mildest forms, they do not have any symptoms. They may come, they may just the physician may do a screening test for thyroid disease because they may have had a family history, something like that, and they may show that the TSH was low. That is what happens in hyper, when the hyper is overactive thyroid. More often patients have discomforting, disabling or even threatening symptoms, life threatening symptoms, and they include all these. One is fast heart rate, feeling nervousness or anxious, and quarrelsome feeling, trembling hands, weight loss, increased sweating, intolerance to warm temperature. You may be sitting in a room where the temperature is normal, but they're saying it's too hot. Muscle weakness, especially of the arms and legs and thighs. This is a cartoon figure which shows all that, a person holding a fan and trembling and so on and so forth. So, that shows they have an enlarged thyroid gland, the heart rate is high, weight loss, muscle wasting. Also in women, menstrual changes, they may not have their periods regularly, etc., and also bulging eyes, things like that. So, what are the blood tests? The TSH is the most common thyroid stimulating hormone. Is the screening test is usually low. If abnormal, followed by the other tests like total T4, total T3, or free T4, free T3. Usually we do the free T4 or free T3. We do not do this that much anymore. And the thyroid antibodies, we do it like this is called the TSI and TPO. So, this is usually the case. What the levels? The TSH normal is 0.4 to 4.5. If it is hyperthyroid, it is less than 0.4. If the free T4 is between 0.6 to 1.8, it is usually greater than 1.8, and the free T3 is 1.4 to 4.2, it is greater than 4.2. But again, these are going by some of the assays. Depending upon where you do your blood test, it may be a little different. This may be 1.4 or 1.5 in some labs, and this may be like 4.5. I am just giving you one reference range there. So, if we are not able to diagnose just by the blood tests, we will have to do a scan. So, why do we need to do a scan? A scan is done because thyroid is the only gland in the body which can take up iodine and can concentrate it. No other gland in the body does that. So, we do a radioactive iodine scan, and usually it is nothing really means dangerous or anything like that. Yes, radioactive iodine, we feel okay. So, we think about nuclear explosions and other things, but again, this is a radioactive tracer which is given to you in an oral pill form, and it is out of your system within 24 hours. And they do the scan at 5 hours after they give you the pill in the morning, and again they do a scan at 24 hours. So the normal usually uptake at 5 hours is between 5 and 15. If someone is more than 15%, then they have hyperthyroidism. And if the 24-hour uptake is usually between 10 and 30, if they are above 30, then they have hyperthyroidism. So this is a normal person, and this is, see how dark it is. This is a person with hyperthyroidism or Graves' disease. That's another name for hyperthyroidism itself. So that is the overactive thyroid gland there. So again, one thing which patients do always ask is, okay, oh, will my eyes bulge and so on and so forth if they have hyperthyroidism. Not all patients have this issue. Some develop and some don't, and we really don't know why. Smokers are at a higher risk to develop this. They have bulging eyes, gritty sensation of the eyes, pressure or pain behind the eyes, puffy or retracted, the eyelids go back up, reddened and inflamed eyes, and they are also sensitive to light, double vision at extreme cases, and vision loss is also can occur. So these are some of the pictures of the thyroid eye disease. Different grades are there. So what are the conditions which cause hyperthyroidism? Another one called toxic multinodular goiter. This is multiple nodules. Some of the nodules just have a mind of their own, you can say, and they start producing more thyroid hormone. So that is mostly over 50 years. Patients have had goiter, which is enlargement of the thyroid gland, for a long period of time. So these are some of the pictures here, but these are like to see something like this in US is very rare. Occasionally you may see, but it's not this size again. These are all the pictures, mostly from the developing countries, Asian countries, things like that. Sometimes you can see those kinds of goiters also when they have a low iodine. The areas don't use iodized salt, things like that. Toxic nodule, this is a single thyroid nodule which can cause hyperthyroidism by producing excess thyroid hormone. And the other conditions are, this is a subacute thyroiditis where there is an inflammation of the thyroid gland, and that releases more thyroid into the bloodstream, and there is pain in the thyroid area and it resolves spontaneously. Sometimes can cause a result in hypothyroidism. So postpartum thyroiditis, this is after the delivery. Usually 5 to 10% of the pregnant women can experience this. Most women recover from it, but sometimes it can lead to hypothyroidism it also. And silent thyroiditis, similar to the postpartum thyroiditis, but not related to pregnancy. So also excessive iodine ingestion. You don't want to take iodine just because someone says, oh, you need to be on a high iodine diet. In America, we have enough iodine in our diet, so we don't need to supplement more with iodine unless really a doctor has a good reason to tell you to take more, increase your iodine. So if someone takes kelp tablets, cough medicines, or also some of them have iodine. There's a medication called amiodarone. 1/3 of the medication is iodine itself. And also if someone is getting a CT, things like that, the IV contrast which is given has also iodine in it, and that can cause hyperthyroidism depending upon how your gland status is before they take any of these medications. And also over medication with thyroid hormone, that also is one of the causes. That's why you need to follow up with your physician with respect to if you have hypothyroidism every 6 months or a year if your numbers are controlled, or maybe even sooner, 4 months or 3 months if they are not controlled. So medications, we use methimazole and PTU. These are the most common. Side effects include rash, very rarely liver function abnormalities or decreased white cell count. If someone goes on any of these medications and they develop a sudden sore throat, we tell them to call their physicians, because their white cell count is decreased and they have a higher incidence of, if the white cell count decreases because of the medication, we have to take them off the medications. Otherwise, they may be at higher risk for other infections. And also beta blockers, these are blood pressure medications which will relieve some of their symptoms. Radioactive iodine is also a treatment if the medications don't work, and the surgical removal of the thyroid is the third treatment if the first two don't work. So when the TSH is lower than 0.4, this is subclinical thyroid, but the T4 and T3 are normal, but the patient does not have symptoms. We usually follow these kinds of patients over a couple of periods, means at least 3, 4 or 6 months, and if they continue to have the blood test problems, we may do a radioactive iodine scan. If they don't, if they normalize, then we just follow them once a year and go from there. So low thyroid, which is hypothyroidism, I think this is more common than the hyper. So again, underactivity of the thyroid gland when it produces less than the normal amount of thyroid hormone, slowing down the body functions. Most of the times it's permanent, sometimes it can be temporary. Some studies have shown that 10% of the women and 3% of men have hypothyroidism. Initially, the glands can secrete more hormone to compensate, but it's not able to keep up, and so the gland basically dies and you have to start medication. The common symptoms are fatigue, drowsiness, forgetfulness, difficulty with learning, that's mainly in kids, dry and brittle hair, and dry, itchy skin, puffy face, constipation is one, sore muscles. Weight gain, again I put it in bold here, has many causes, but thyroid is one of them, and fluid retention, heavy and or irregular menstrual periods, increased frequency of miscarriages in women who are trying to get pregnant, and increased sensitivity to many medications. This again a cartoon figure which shows the hypothyroidism here, the different symptoms and some of the signs here. So again, the causes are this is autoimmune, which is your own immunity is producing antibodies and that's attacking your thyroid gland, and you're producing less hormone because of that. After radioactive iodine or surgery, we discuss that as a treatment choice for hyperthyroidism. And spontaneous, for no apparent reason. Sometimes we may not find a reason. Sometimes patients come and ask me, okay, why am I hypothyroid? You're telling me all the tests are negative except the TSH is high and I'm feeling cold and so on and so forth. The reason is spontaneous or idiopathic. We don't find a cause. Medications, high dose of iodine, amiodarone and lithium can also cause hypothyroidism. I discussed about subacute thyroiditis, which is initially a cause for hyperthyroidism, but it can lead to permanent hypothyroidism. And the postpartum thyroiditis, I discussed this earlier, initially can be a cause for hyper, but after pregnancy can lead to hypothyroidism and usually may need medications. So I think that's and also pituitary hypothyroidism. When someone has pituitary surgery or radiation to the brain, your pituitary does not produce the TSH, so your thyroid cannot produce the T4 or T3, and it's a rare cause of hypothyroidism there. It's another cause. And blood test which needs to be done is the TSH, which is usually high, free T4, free T3, which are usually low, and no scans are required to sort of find out if you are hypothyroid. And again, this is hyperthyroidism, the TSH is low and the T4 is high. In hypothyroidism, this is the primary one we are talking, the TSH is high and the T4 is low. So this is a slide which initially shows a lot of times the TSH starts going up very early compared to the T4 and T3. So this is a more sensitive indicator, and that's what we follow in most patients with thyroid issues or hyper or hypo. So treatment of hypothyroidism. So some of you may be on these medications. Again, levothyroxine is the generic, Synthroid and Levoxyl are the brand name medications, usually based on your weight. Some cases, elderly or patients with cardiac issues, we may start at a lower dose and then go up. In most cases, treatment is needed for life. It's not like you take it for 3 or 4 months and then stop it and you go back to normal. Not that way. Periodic monitoring of the TSH is needed for optimal treatment, and thyroid tablets, they come in 11 or 12 different strengths based on the manufacturer. It should be taken on an empty stomach or at least 45 to 60 minutes before eating. Best time to take it in the morning before eating or before going to bed. Please pay attention to the time of the last meal of the day or 2 to 3 hours after the last meal. If calcium or iron are taken together, you want to take it 4 hours after taking calcium or iron. So this is important. Thyroid medication is what we call as a narrow therapeutic index medication. What I mean by that is even a small change in dose can affect your blood test quite a bit. So when physicians are making changes, we have to be careful, because if we change your doses too much or too little, then your blood test can vary significantly. Let's say someone is over-treated and they are hypothyroid, and we decrease their medication by 50%. We have to decrease it maybe just 10 or 12% and then recheck the blood test in about 6 to 8 weeks or 8 to 10 weeks, and then again reassess and go from there. FDA does say that both brand name thyroid medications and generics are the same, but as endocrinologists we have a different view on that. The reason for that is if someone is getting 100 micrograms, it may not be 100, it may be 95 or 105, and as a physician I don't know that, as a patient the person doesn't know that, pharmacist doesn't know that. So the FDA does give that leeway to the manufacturer that it can be 95 or 105. So that's why some patients where thyroid levels fluctuate quite a bit, we tell them at least to take brand name medication and go from there, which was there in the previous slide. And this has been actually so post-marketing drug safety information in FDA 2015 did say that that was the case. There is a discrepancy in doses in the generic manufacturers. So I'll clip this slide. Basically this shows that just by taking thyroid, if someone is taking thyroid for weight loss, it does not work. Majority of the studies shows that they didn't lose weight. There are a few studies, a couple of different studies, it shows they lost weight, but majority shows that they don't lose weight. If they don't have hypothyroidism, but they're taking thyroid medication for weight loss, it does not work. So not effective as a weight loss drug, may increase the metabolism, but also increases your appetite. So you probably end up eating more. So these are the colors of the thyroid medications. The generic, the brand name, everyone is the same. The color should be the same. They're not any different, but the shapes are different obviously based on the manufacturer. So treatment of thyroid means hypothyroidism, most endocrinologists with respect to do not use cytomel, which is T3. Sometimes some patients come to us and say, oh, I want T4 and also T3. T3 is the other active hormone. So they think that they may not be producing enough T3, so they want T3. There's not a strong evidence to support that. In some cases when you use T3, you have to take it twice a day, or in most cases you have to take it twice a day, I would say. And there's another one called Armour thyroid or Nature thyroid. This is a combination of T4 and T3 together. So FDA has approved these medications for use as it was already being used. So there was no trials or anything like that. It was being used previously. Then FDA said, okay, it's already in use, let's just approve it. Personally, in my at least personal experience, sometimes it's very difficult to control the blood test levels when you're giving these medications. But again, you'll have to adjust the dose and see if it is, otherwise we have to change them to the levothyroxine or Synthroid or Levoxin. So hypothyroidism and pregnancy, it's not very clear if all women planning for pregnancy need to be tested for thyroid disease, but if they have a family history and other things, definitely you need to test them. High risk patients with hypothyroid symptoms or family history, yes. If women is already treated for hypothyroid and they get pregnant, they need to get their labs tested as soon as they get pregnant, and also probably every at least 6 to 8 weeks, that's what we say, and adjust their doses. Most of the time we do adjust them proactively once they get pregnant and then follow the blood test. If they're not treated, the increased risk for anemia, premature birth of the baby, and also miscarriage. Again, after delivery, dose needs to be readjusted, because if the dose has gone up during pregnancy, you'll have to decrease the dose after the delivery. So that's the end of my talk.